All right, everybody, welcome. We're going to get started. Thanks, everybody, for coming. Thanks for those who are with us in the room. Thanks for the folks who are on Zoom who couldn't make it in person. We're really excited to have everybody here and very excited to have our very distinguished speaker with us today. This is the UVA Medical Center Hour, and I'm Justin Mutter. I'm the director of the Medical Center Hour. And this is a program of UVA's Center for Health, Humanities, and Ethics, which has been running for over half a century here at UVA, quite a long time. And it has always been this forum for engaging these key questions of what is timely, what is critical for us in health, medicine, and society today. Today's event continues in that tradition as we engage the question of what is sustainable healthcare? What should it look like in the 21st century? Today's distinguished speaker, Dr. Jonathan Perlin, has led an extraordinary career guiding institutions to answer just that question. But before I introduce Dr. Perlin, just a brief word on administrative issues about this session, because we are running both on Zoom and here in person. For those in the room today, when it comes time for questions from our speaker, please raise your hand, and you'll notice if you've never been in this room before, there are microphones in front of every seat, which is makes it very easy. And you press a little button, and that turns on your microphone, and you can ask a question that way when designated. For our friends on Zoom, if you would like to ask a question, please go to the Q&A tab on your Zoom screen and ask a question that way. I will monitor those, and I will relay those in due time to our speaker. Lastly, for continuing education credit, we are fully accredited to provide continuing education credit for health professionals. And just a really brief word about how to do that. There are no pertinent disclosures for today. Those of you that may not be familiar with this, there's a way to do this at uvacloudcme.com, but you can also text to this number right here. And the key thing, of course, is the code to claim your credit, which is 27595. All right, so I am very delighted to introduce Dr. Jonathan Perlin to our Medical Center Hour community. Dr. Perlin is the 7th president and CEO of the Joint Commission Enterprise. As many in our audience know, the Joint Commission Enterprise includes quite a few entities, including the Joint Commission Resources, Joint Commission International, and the National Quality Forum. Dr. Perlin will be speaking today about some of the innovative efforts that he has designed and launched through the Joint Commission Enterprise. But prior to his tenure with the Joint Commission, Dr. Perlin was president of clinical operations and chief medical officer of the Hospital Corporation of America. And before that, he was Undersecretary for Health for the Department of Veterans Affairs. His list of accolades is too long to recount in full, but highlights include chair of the Special Medical Advisory Group of the Medicare Payment Advisory Commission and membership in the National Academy of Medicine. He maintains faculty appointments at Vanderbilt University as a clinical professor of health policy and has been perennially recognized as one of the most influential leaders in healthcare. We're grateful for Dr. Perlin to take time out of his very busy schedule to join us today, and here, I should say, at his undergraduate alma mater. Welcome back to UVA. Thank you.
Thank you very much, Justin. Well, good morning. It's great to be here with you, and it is incredible to be back in Charlottesville. When I arrived, I felt like I'd landed on a different planet. It's not the same place, but it's great to see friends, Dr. Jadip Kapoor, Dr. Ed Bertram, with whom I worked prior to medical school. And while Charlottesville has changed, they haven't changed a bit. So it's wonderful to be here. And Justin, thank you for that very kind introduction. You obviously got the email from my mother. It's really a treat to be with a group that I know is committed to doing good. And I want to congratulate at the outset, because I know UVA is focused on sustainable healthcare. Hannah Hawthorne and Matthew Meyer and others who've led actually the medical center receiving sustainable healthcare certification. Now, a quick question. How many of you have spent your professional careers studying the climate effects of healthcare? Me neither. That's a confession. But once I learned what I learned, you can't unring the bell. And so I really wanted to share with you my learning journey in this area. And I'll contextualize that with a little bit about what we're doing at the Joint Commission. As Justin said, I don't have any disclosures for this, and learning objectives are to really articulate the impact of healthcare services on health and equity and safety and organizational resilience. Second, to understand the major sources of our carbon footprint in healthcare and some mitigation strategies, and really give some practical thoughts as to why this is not only socially important, clinically important, but why it's financially advantageous for organizations to address these issues. First, let me thank you all for what you do. There has never been a more complex time in healthcare. When you think about healthcare financially, clinically, operationally, and dare I say politically, there's never been a more complex time. And coming from operations, get the challenges. Healthcare organizations are struggling with all of those issues. Patient disposition is one, and I know that my organization falls into the bucket of adding to regulatory burden, and we're trying to lighten that. We know that healthcare workers themselves are struggling as well, and that some of the tensions in the environment really do lead to a toll on those individuals. We still know that we're not where we need to be in terms of patient care, that you can get the best care in the world, but not every patient gets the best care each and every time. We have opportunities in all of these areas, but here's the challenge. We've got to multi-solve. You can't just focus on one. Patients deserve a right to excellent care. Communities need access to services, and we need a safe and healthy working environment for those who provide care. And so the precepts of the triple aims still hold: cost, quality, and experience. But to that, I think we have an obligation to still focus on health equity, to focus on something that, frankly, I underestimated prior to COVID, the importance for caring for ourselves as a caregiving community to be effective, and something, as I said, that I didn't know about, and that was sustainability. Just a brief history of the Joint Commission. Why is the Joint Commission called the Joint Commission? Well, nothing to do with joints. Has everything to do with its joint founding after World War II by the American College of Surgeons, American College of Physicians, Medical Association, Dental Association, and Hospital Association. They picked up on work that Ernest Codman started in 1913. At the same time he founded the American College of Surgeons. Healthcare became technical, and as a profession, it was actually us, clinicians, who said, we need to be sure that there's the technical capacity for safe and high quality care. Following World War II, physicians used to run hospitals, all got drafted, came back, there was a shortage. American College of Surgeons said, we can't do it alone. We need some help in doing this. Went along as a voluntary program until the Great Society and the instantiation of Medicare in 1965. And Joint Commission was an extension of government to be able to carry that forward, and that's how we operate today. I'm really proud of our vision statement, that all people always experience the safest, highest quality, best value healthcare across all settings. You probably noticed that all is in there 3 times, and it operationalizes health equity in that way. And indeed, it was seeing the dislocations of COVID that led me, when I came to the Joint Commission in March of 2022, to want to put health equity at the absolute top of the list of what became the HELP agenda, which, as you can see, is an acronym for health equity, environmental sustainability, learning healthcare, which is really about responsible use of secondary data created for clinical purposes that are used for discovery, operations, improvement, and learning, and responsible AI, and performance integration to get rid of stupid stuff and focus on those things that really matter most, like the first 3 things that I mentioned here. What took me specifically to health equity, tell you a little story, is that I was at HCA Healthcare. We had the opportunity to provide maternal care to obstetrical care for the delivery of roughly 250,000 babies a year. And we'd set the system up as a big sort of learning platform. And I think you know the statistic that in the United States, women of color experience significantly higher maternal mortality. Black women about 300 to 400% higher, than white women, and Latina about 150% greater. And you probably know that that disparity persists not only in the period of pregnancy and in the year that follows, but it actually is exactly the same in the hospital as well. And through a lot of work over a number of years, in 2018 and 2019, do you know how many women of color succumbed in our hospitals during that period? 0. In 2020, things changed rapidly, even by October. 19 women showed up at death's door, 2 from COVID, 17 really. The root cause, the root diagnosis was dislocation from access to services. Individuals at death's door because of overdoses, individuals at death's door because of untreated cardiomyopathy or untreated cancer. And so it was really clear to me when I came to the Joint Commission, if I had the opportunity to pull a lever, this is the one I wanted to pull. Well, since we're going to dive deep on the environmental sustainability, I'm going to mention the other 3 areas first. Now, my favorite quote from King on equity is this: of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. He said that in 1966, 60 years ago roughly, and it's often misquoted. It's often quoted as inhumane. He didn't say inhumane, which means cruel. He said inhuman, beneath humanity. And recently, a scholar named Charlene Galarno at Wellesley actually went back and found the source literature. He spoke 3 times that day in Chicago, and he's quoted verbatim. And he also didn't use the word healthcare, he used health. And 60 years ago, he prognosticated what we still see today. Using the OMB nomenclature, Black Americans experience over twice the age-adjusted mortality than white, and using that same nomenclature, American Indian, Alaskan Native, even higher. But if you're not swayed that this is an issue on a moral basis, it's an issue financially. Unmet needs lead to excess care utilization, which costs today. I know I spoke to the first author of this publication yesterday. And when it was published, it was $320 billion per year. It's now about $345 billion per year. And unaddressed needs that lead to excess care ultimately by 2040 will cost a full $1 trillion. So I hope one's swayed for the moral reason, but as an economic opportunity, it is there as well. Let's talk about AI for just one moment and our interest in that. This is the defining technology of our century, and it offers the opportunity for a step change in all aspects of healthcare performance. Many know about an insurance company that used an algorithm to try to improve heart failure outcomes for Black patients. It backfired. The biases in the training data were not appreciated. Instead of ameliorating, it amplified the biases in care. On the other hand, in my old team, we developed a sepsis algorithm that saved 8,000 lives over 5 years. I want to be able to use those technologies, and so we're working on developing a certification for AI to assure that there are appropriate guardrails, but that it's led by scholars and people in healthcare so that we're not stifled by overregulation and legislation. Because we need to do that. This one for any medical students in particular who are out there, I want to just show you the complexity of medical decision-making, the way I think about it. And in the context, there's a paper by Andy Arbach published last year that showed that 23% of patients who deteriorate and die in hospital do so because of a missed or misdiagnosis. Well, how tough is diagnosis? Now, my friend Bill Stead at Vanderbilt published this paper. Now, for those of us old enough to remember 7-digit phone numbers, there was a reason that at the turn of the 20th century, phone numbers were 7 digits, because the psychometricians actually found that we can manage between 5 and 9 variables simultaneously. So hold the number 7 in your mind for a moment. In the average ICU on every day, there are about 1,000 new facts or data points, and there are about 300 orders in effect at some level. So that's 1,300. Okay, the mathematicians in the group are quickly saying that, well, that's a factorial relationship, i.e. 7 times 6 times 5 times 4, and you come up with 5,040 permutations. So here's the mind teaser. What is 1,300 factorial? Is it a million? Is it a billion? Is it a trillion? Am I leading you down the garden path? Matthew's saying yes. I absolutely am. That number is staggering. Head-spinning number of 3.16 times 10 to roughly the 3,500th power. Okay, how big is that? Is that as big as the number of grains of sand on the planet? Not even close. That number is actually larger than the number of particles thought to exist in the finite universe. Okay, long way of saying, look, we're human. We need help. And this is a defining technology. And this is why we're really excited about some work that we're doing on responsible use of secondary data, responsible use of AI to really help to move things forward and allow that to be led by leaders. And I won't go through all of this other than to say that the protections are really agency over the use of data with benefit to individuals, benefits to populations through data security, privacy protections, and importantly, assurances that there's a governance process that says, okay, is the math right? Algorithmic verification. Is the clinical knowledge right? Evidence verification. And is there appreciation of biases? Is there cultural competency to understand what could go wrong? And so we're really excited about this area. And finally, I just want to close this section before we get to the sustainability on what some people in healthcare experience but may not understand. We survey to standards at the behest of the Centers for Medicare and Medicaid Services. Organizations can't get paid by federal sources without an accreditation. And most of the standards come through law or regulation, that is executive branch orders, and things like water bottles famously come from OSHA. And those are not under our control, though we were looking forward in this administration to influencing perhaps some relief of those things that really don't have a strong evidence base. But we got rid of 400 standards that didn't have a strong evidence base. And I know for those with administrative responsibility, it didn't break any hearts. And we put only one in, and it was directional, and that was health equity. And we didn't say solve transportation, solve housing. We said, look at your own data and stratify. Now, having spent a career in quality, I would tell you that sometimes if you spread peanut butter to try to make something better, you miss the opportunity, you tamper with the system, and you may not get any improvement. In fact, you may get average deterioration. If you actually segment and stratify on a number of different features, you may be able to find exactly where opportunities are. I can tell you that for reasons, even adjusting for comorbidities, in health systems I've worked with, that you can find unexplainable variations in central line infection rates, as an example, adjusting for clinical comorbidities. And when you find out that those central line infections are localized to subgroups of the population, you have to ask the question why. But that means you can also go to the source and actually gain performance advantage much faster. Here, our focus was equity, and I'm really pleased that as a result, in many instances, I know some institutions were on their journey, but sadly, quite a number weren't. You can see the sorts of things that organizations focused on: mental health, maternal care, cancer care, patient experience, diabetes screening, and fundamental social determinants: food, housing, affordability, literacy. And this is brand new data this week from the American Hospital Association that those organizations surveyed under the new equity standard by the Joint Commission had statistically improved different overall health outcomes, better clinical outcomes, lower utilization, and decreased costs. And so I really like this because it speaks to something I've long believed in, and I think is in the data, and that's that good quality is always good business. Okay, well, let's turn to the subject at hand. Things I didn't know, things I learned. That if healthcare worldwide were considered a country, it would be the 5th most polluting country. And if the United States were a state in that country, we're overachieving. We'd be 27% of that carbon footprint. And on any given day, almost 9% of all emissions in the United States come from the practice of healthcare. So as an unintended and untoward consequence of our desire to do good, we're doing harm. In fact, in 2021, the British Medical Journal, along with 233 other journals, simultaneously published an editorial that ultimately 60 more journals joined onto that said the climate change is the #1 threat to public health worldwide. But I hope to show you in the next few minutes, this is not only an environmental issue, social justice issue, but a health equity, and patient safety issue, and it is an operational issue. According to the T.S. Chan School of Public Health, over the last 3 years, roughly 4 out of 5 primary care clinics were closed for at least one day because of extreme weather events directly attributable to climate change. And when you think about it, if they were closed and there was an extreme weather event, their community needed those resources exactly at that moment. So we all know about the relationship between carbon dioxide and temperature, and here you can see the last 100 years, but a climate skeptic might say, well, that's 100 years, that's less than a blip in evolutionary time, geologic time. Well, let's go back 1 million years. Let's go back 1 million years, and if you dig into carbon matter that's been buried or ice, you can find that every time that the carbon in parts per million reached 350, the temperature was at its highest. And every time it came down commensurately, but that was the peak out and the Earth recovered. Today, sadly, we're at 424 parts per million, and the increase has not been linear. It's been escalating rapidly over the last 15 years. And some of you, like me, may have heard that we have to control warming to 1.5 degrees. Well, what I learned is that's not 1.5 degrees Fahrenheit, it's 1.5 degrees centigrade, and it's not 1.5 degrees from now. It's 1.5 degrees from the beginning of the industrial age. And it's not 1.5 degrees that we have left. It's less than 1/10 of a degree, and it may even be 0.5 of a degree. And so there's very little threshold. And when you hear we have to get to net zero by 2050, why is that? Well, if we want to get back to 350 parts per million by 2100, then the trajectory is to cut by half by roughly 2030 and to net zero by 2050. And while I'll be really old in 2100 as the parent of a newly married daughter, I know that her kids will be around, and I hope that they have a better world. But worse yet is that as a parent of a daughter of that age, it's like, do I really want to bring a child into a world with the climate effects? That's a really sad thought. If we get up to 2 degrees, I just want to show you what the devastation could look like in a number of areas. If we go down to the bottom right, look at Miami, 94% of a 2 million population will be underwater. And you can look in New York and Houston, London, Mumbai, India, Zhengzhou, China. These areas are massive. Half of a 7 million person population in Zhengzhou will be underwater. And there are already island nations that are experiencing existential threat. And not so far from here in the Chesapeake Bay, there are a number of islands that have persisted for millennia that are quickly disappearing. Well, let's look now at the climate effects on health. But first, we'll note that there's an unvirtuous cycle that as temperatures rise, ice caps melt. As ice caps melt, more carbon dioxide is liberated. So it's not only the human activity, but the effect of human activity on the natural environment. And so there's this unvirtuous cycle that occurs. And as we look at the actual health impacts, a couple things to keep in mind. First, for the exact same reasons that adverse social determinants predispose to bad outcomes, the most vulnerable are the least able to compensate. They can't buy their way out of harm's way. And second, while it's not surprising that things like respiratory and cardiovascular disease are exacerbated, so are a lot of other disease mechanisms as well. This is a great book. It has both the narrative and the data. But from this book, when we think about firearm deaths, we think those are totally out of control. In 2022, 250,000 firearm deaths worldwide, and in that same year, roughly twice as many deaths from extreme heat. 2022, 30 million people living in extreme heat areas. Think about this, the population of the Earth is a little over 8 billion. Some people think that may be underestimate, maybe it's 9 billion. But in 2070, a full 2 billion people, a quarter of the current population, will live in extreme heat. But this is a statistic that's particularly frightening and was published in JAMA last year, is that the heat death rate is increasing 17% year over year for the last 7 years. And there's that curve on the right-hand side. And we experienced the hottest summer on record last year. Well, what are the mechanisms that confer vulnerability? Well, part is urbanization and isolation into areas that don't have green space, the built environment that retains heat, that work activities, air conditioning, cars, et cetera, generating heat. You might think things like ponds cool off in the day, but they retain heat at night, and only green space actually leads to cooling diurnally and nocturnally. Well, what happens then if you have a heat wave in one of these built environments? Well, the most tragic example of that was in Chicago. The orange line is baseline deaths on a daily basis, and it's the heat wave of '95 that's been intensely studied. And I think you don't have to be a statistician to see a signal change in the red line, 700 deaths over a period of that heat wave. And then here you can see how climate change interacts with health equity, who is affected both, not surprisingly, individuals over 65, but also non-Hispanic Blacks, as an example, from data from the CDC. Factors that contribute to that, same mechanisms: demography, geography, biology, sociopolitics, socioeconomic, that predispose to greater risk under all of the extreme weather and heat, air quality and water quality and food and vector. Well, let's dive into those now. So this is not a picture of Katrina. This is a Hurricane Ida in 2021 in New Orleans. And so, during a weather event, obviously patients are dislocated. But on the other side of the Gulf, here is Tampa General Hospital, University of South Florida. And by the way, that visitor parking is also the exit for their emergency department. And so that didn't work so well. So what have they done? They put up 12-foot flood barrier walls. But we can't put that up around the country, around every environment. And the fragility of living situations also reflects the fragility of the healthcare infrastructure. Well, let's move on a little bit. Forced migration, civil conflict, mental health. That's got to be somewhere else. Tropical diseases, waterborne diseases, cholera, as an example, algae blooms. That's somewhere else, right? Well, not so fast. This is last year and the year before in Florida. These were the red tide outbreaks. And okay, let's go from that to migration. How does that work? Well, imagine that you're a fisherman on the Gulf, and you have a $250,000 mortgage on your boat that you're proud of, and Mississippi Delta on the left, or off the coast of Florida, that happens to be Captive Island on the right, is where you usually fish. You've migrated, as has happened the last few years, up the East Coast to the Carolinas. And here, if you're a fan of Chesapeake Bay crabs, as I am, they're moving up to Boston Harbor. New England lobsters are moving up to Nova Scotia, and that's changing. And this picture is a picture of verdant land with animals grazing and crops growing. Well, not. Only a few years ago, that's exactly what was there, and that's why the organization that sets the goals, the Intergovernmental Panel on Climate Change, met in Panama, because this and is no longer arable. It no longer supports not only animal life, but plant life. And in the United States, many of us grew up with this framing. The United States was the breadbasket of the world, breadbasket of North America, certainly. But as temperatures change, that breadbasket shifts north, and that changes migration of jobs as well. But this migration operates at a worldwide level, and you can see that there is this exodus that's predicted and is beginning to occur from tropical and subtropical latitudes to the higher latitudes, both in the northern and the southern hemisphere. Well, what about vector-borne diseases? When I was a medical student, I didn't study chikungunya real hard. First off, I couldn't spell it. And second, I thought I'd never see it. Not so. Let's first take a look at mosquitoes. You think of mosquitoes just as a noxious summer pest. It's a really interesting fact that since humans became humans, it's estimated that about 104 billion of us have lived. Weingart calls the mosquito the apex predator because vector-borne diseases have killed roughly half of all humanity that ever existed. And if you think about that disease that I didn't study real hard, chikungunya, if you took a string and wrapped it around a globe at the latitude of the Canadian-US border, every area that has reliable epidemiologic data in the Northern Hemisphere would report chikungunya. And if you look at the distribution of the Aedes mosquito, in 1960, it was really a Gulf Coast phenomenon. And today, all the way up to the Canadian border, all the way not only to, but even west of the Mississippi. And if you look at the diseases that are brought by the Aedes mosquito and the Anopheles with malaria, all of those diseases in Maryland, there were 2 cases of malaria last year, and I believe there were a couple here in Virginia as well, certainly in Florida. And if you look at those mosquitoes flying around bringing dengue, and you look at this map and say, wow, there's dengue up in Washington State and Illinois and Michigan, et cetera, and there are other states that don't have it. Oh, they have it. They just don't know it. They didn't recognize it. And it's not something we grew up with. Dengue translates from the African term that refers to break bone fever. And when you have dengue, it feels like your bones are breaking from the inside. And that's if you have a good case of dengue. If you have a bad case, it fulminates to complete cardiovascular collapse and death. Now, the good news is there are some vaccines in development for dengue, but the bad news is that we have dengue at latitudes that it never would have existed 50 years ago. Okay, I hope I've made the case that this is not only a social and environmental issue, but a health issue, a health equity issue, an operational resilience issue, and a patient safety issue. So let's flip the script a little bit and say, okay, how do we create waste and what can we do about it? Well, when you talk about the greenhouse gases, there are three scopes, basically simplified what we do directly, the fuel we use to power our buildings and vehicles, and the stuff that we use. As you look at the stack, you might say it's only 7% in the stuff we do. That 7% is a really potent 7%. Talk about the relationship of carbon to global warming. Well, it turns out that fluorinated anesthetics and the propellants in meter-dose inhalers are 1,600 to 3,600 times more potent in global warming than carbon dioxide. And if you look at anesthesia, for example, with isoflurane and desflurane, there are alternatives. One simple maneuver to not put so much of this stuff into the atmosphere is just turning down the flow rate on the anesthesia, because otherwise you're just sending expensive anesthetic by the patient and venting it out to the atmosphere. Kaiser Permanente saved $20 million in a year simply by mandating a reduction in fresh gas flow rates. And Matthew is way more knowledgeable than I am on this. If you have any questions, he's the person to ask. Nitrous oxide is also horribly toxic, and old hospitals with leaky pipes tend to be the mechanism of escape. And so just using a local tank is the best way. The meter-dose inhalers, there are now breath-powered inhalers, and they're developing just compressed air inhalers. And so over time, we'll have the ability to move to different products there. But if you look, for example, at Seattle Children's Hospital through their Project Spruce, they've eliminated fluorinated anesthetics entirely. And as Don Berwick says, always good for a quote, great thing about benchmarks is that they're not theoretical. And my favorite benchmark is the National Health Service, which has vowed to get to absolute net zero, not by 2050, but by 2040. And they're on track to eliminate both the overuse of the meter-dose inhalers as well as the fluorinated anesthetics. What about power? Well, healthcare is about 5% of commercial space, uses 10% of the power, and 3/4 of that is in hospitals. That's a lot of power consumption. So we need to build smarter, and that's why I'm really proud of the certification that you all have obtained, because you're actively thinking about that power usage. Up to this year, we've had the IRA incentives for organizations that invested in green energy and greener buildings. And obviously, the best way not to use hospital resources and power is to keep patients healthy. So there's an imperative to really think holistically about prevention and public health as one of the mechanisms of improvement here as well. Well, I will say this, that it does take some capital to do all those things. But a friend of mine who runs the 3rd largest hospital system in the United States is not only committed to building a green system, but he's hedged his energy prices for the next 20 years. Obviously, this is an incredibly volatile moment in terms of the cost of healthcare and the effect of revenues of all the current policy. But hedging your energy prices for 20 years is a really smart financial deal. Sometimes the maneuvers are really simplistic. They put awnings on the old building at Memorial Sloan Kettering, cut their summer energy consumption by 30%. And again, the National Health Service net zero by 2040. There are landfills that are dedicated just to medical waste. And did you know that every patient in a hospital generates about 20 pounds, or every bed, about 20 pounds of waste per day. So think about that. For every 100 beds, that's a ton each day. And 15% of that ton is infectious, toxic, sharp, radioactive, or otherwise hazardous. How do we actually get a better handle on the consumption? Well, here I want to introduce you to a friend of mine. Her name is Maria Koyak. She's a nurse. She's a performance artist and a climate activist, and by public acknowledgement, a breast cancer patient. And she wanted to show the impact of her breast cancer surgery. So she made a strange request when she went into the hospital for a single breast reconstruction. She said, "Can I have the waste from my surgery?" This is in the Netherlands, and you'll be pleased to know there are some constants in the universe. The team said, "Well, we have to talk to administration." Administration said, "We have to talk to our lawyers." And after all of those discussions, they came back and said, "Yes, you can have." And at discharge, she was presented with 600. Some of that waste can't even be reprocessed at all. But there is evidence that says infection prevention is worse with longer gowns than disposable. And we've got amazing What will you do? What will we do? Well, at UCLA, they switched from disposable gowns to launderable. And even as a couple of years ago, they not only had saved 300 tons of waste, but they saved over $1 million. Cleveland Clinic, where they have over 100 operating rooms going at any given time, they've made a number of interventions from LED lighting to reprocessing instruments to diminishing the disposables in lieu of launderable. They save 20,000 per OR per year, and that's ongoing. And the Joint Commission, our former chair of the board, Carlos Pellegrini, former chair of the American College of Surgeons, says, you know, the mission trips he does to South America using the same hemostats they threw away at University of Washington 20 years ago are still working perfectly. We have an opportunity to do better. And that's one of the extreme areas. And again, National Health Service, Net Zero 2040, addressing all of these things. When we think about how we might buy in the future, you know, it's pretty interesting because if we go to the store and cost the same, taste the same, et cetera, if you're trying to watch saturated fats, then you look at the food level and you make a healthier choice. Well, we need that food level on the products by the line item and by the market basket. And if you have a Logitech mouse, this one's Kensington, not Logitech, but every product, they have the carbon footprint on it, so you can shop that way. We need to demand that we change this. We actually committed to 50% reduction at our organization by 2030, net zero by 2050. I would tell you when we came up with some initial guidance, it was not well received. Some people said, well, you, the Joint Commission, are causing us to waste. And the harshest critic was an anesthesiologist, Dr. Jody Sherman at Yale. And we invited her to chair a technical advisory panel. They went through said, well, it doesn't actually say use single use. So he said, scrub it and change the tonality so it doesn't even imply that. And so we did. But we also put out some proactive recommendations that were greeted not well. Well, wildfires in Canada, orange skies, red sun in New York, wildfires in Maui, catastrophic flooding in California, flooding that led to the Vermont Hospital Association being dislocated from their building in Montpelier, fish kills, fishery migration, et cetera, and things changed. We're part of a movement. We have a workforce shortage in healthcare. You ask any executive their top 5 issues, it's workforce, finance, everything else. Younger individuals want organizations to be proactive. In fact, over half say they won't work for organizations without a commitment to environmental stewardship. And it's rare that when I observe surveys, we're asked to add standards. And when I go in a hospital and talk to individuals, I see head noddings. They say, hey, we want you to add standards in this area. Commonwealth Fund last year surveyed physicians and nurses, and they found that roughly 4 out of 5 think that they personally and their institutions need to do more in terms of environmental sustainability. So that's on our side. Since you have the Sustainable Healthcare Certification, I'm not going to go through it, but it's an organizing framework for organizations that, unlike University of Virginia, have not made that start. Well, we were chatting earlier, I'm a recovering English major, and there's a difference between hope and optimism. Hope is a feeling, and optimism is based on experience or data. And here's NHS putting it all together, net zero by 2040, so it can be done. So in closing, why do this? Well, I think the evidence is increasingly inescapable, and I hope that compels people to come along on this journey. And I hope that they'll attach to this being an environmental and social justice issue, but for those of us in healthcare, I hope the data have convinced you that it's also a health equity issue, a patient safety issue because of the organizational resilience issue. I hope that you appreciate the link to finance, that this is a workforce issue, a retention and recruitment issue. And that, as with my friend at a major health system, hedging energy costs for 20 years, that is a financial opportunity. But fundamentally, I can't recite the mission of the University of Virginia off the top of my head, but I would bet that it says something about caring for the community and improving health. It's inconsistent with our missions. And I know for me, it's inconsistent with my personal mission, my ethos of why I came into healthcare, into medicine. So I think it's something that we have to do. But at another level, you know, we have to really think about what's the why. And for me, that why is even more simple than that. As I mentioned, parent of a relatively recently married daughter, I don't want her to hesitate in thinking about kids, and I don't want her new husband or their kids to wake up to orange skies and a red sky. I want them to wake up to the same blue skies and golden sunshine that I got to enjoy. So really, thank you so much for what you do. Couldn't be more proud of all that you're doing. It's exciting to come back to such a vibrant, thriving medical center. It's a treat to see old and dear friends. And I hope that I've helped you with your armamentarium of reasons to really carry this mission forward, not only at UVA, but through all the work you do as a matter of our collective mission in healthcare. And thank you. Do you want to acknowledge my dear friend and mentor, Eric Lothman?
Thanks. Thanks so much. Just want to remind everybody, if you want to use your microphone right in front of you, you can. Those of you in the room, just raise your hand. If you have a question, then our friends on Zoom, feel free to put in something to the Q&A tab.
Good, and there's no question I won't answer. That's, feel free to shoot your hardest question over.
What are some low-hanging fruit options that medical centers or systems can do to help reduce the waste?
Yeah, great question. What are some of the low-hanging options for reducing waste at medical centers? I think, you know, the playbook at Cleveland Clinic is a really good one. There is a battle going on of disposable versus launderable gowns, bonnets, booties. And as I said, the evidence is really clear. There is absolutely zero difference. And so that's probably one of the easiest places. Second, in terms, and a lot of materials consumed in procedures. In terms of you know, surgical preference trays, you actually need to quantify what's used and what's never used. Do we really need to process a bunch of stuff that's never used? In terms of the environment, you know, a lot of places just have air cycling that's really way beyond what's necessary, or air cycling that occurs during off hours. There's great opportunity to optimize there. I think you heard about the, you know, it was pretty straightforward in terms of the fluorinated anesthetics. It is a challenge, particularly in pediatric population with some of the inhalers, but there's opportunity to make progress there. Having conversations, when you have young colleagues, staff members, I know that it's easier for a nurse to pop, even though you're not supposed to put it in the microwave, a chlorhexidine towel that's in a plastic bag into a microwave for 15 seconds and carry it over than it is to have a chlorhexidine that's poured out of a bottle and is using a launderable towel or something of that sort. But conversation's a little different, is that if you engage around the conversation of what the impact is. I've watched units say, hey, I know this will take a little bit of different effort or slightly different effort. It really doesn't take that much different than time, but we can move in those directions. So those are some of the ways. And there are some communities that have just lists of recommendations of what to do. Practice green health, healthcare without harm, and on our website and on the National Academy of Medicine's website at the Action Collaborative on decarbonizing U.S. healthcare.
Thanks so much for this. I was really struck by your quote halfway through that good quality is always good business, which I think it is probably true on some time scale, but it's sometimes hard to make that case on a more immediate time scale. At least I have found, working in primary care, often getting pushback on what feels like good quality measures for patients from a financial perspective. So I'm just curious, either in terms of the health equity materials you're talking about or the sustainability, how you think about making that case to administrators and how you see American healthcare changing in the next generation to make that case even easier and more straightforward.
Yeah, great question. How do you make a case for good quality being good business? I had the great privilege to meet with Dr. Hoke this morning, and I loved the way she had a couple of buckets. One bucket was it has good quality outcomes and it has financial return, and the other, it has good quality outcomes and we should just do it. And I remember when I was at the largest private health system in the country, HCA, I remember coming back with all the financial on one.